1, 2,
And review 70-year-old female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
Imagine you're walking into an ICU room. Your patient is sweating, leaning forward in a tripod position, just speaking in these 2-word gasps.
Right, maximum effort.
Exactly. Their heart rate is like 135. But you look at the monitor and the saturation is hanging out at 92%. And then suddenly, their respiratory rate drops from 38 down to 14.
And that's the trap.
Yeah, because if your first instinct is to think, oh, great, the breathing treatments are finally working, they're relaxing well, your patient is actually about to code.
Yeah, they are seconds away from an arrest.
So welcome to the deep dive. Today, we are aggressively applying the Pareto principle, the 80-20 rule, to the single most critical system you manage at the bedside, acute respiratory failure and its most violent evolution, acute respiratory distress syndrome, or ARDS.
And we are really stripping away the fluff today,
Yeah.
Because just knowing the textbook definition of respiratory failure, that is not going to save the person in front of you when those compensatory mechanisms just abruptly fail.
Right. We're acting as your elite intensivist team here.
Exactly. We're focusing purely on what gives you that massive clinical understanding, the exam performance, and most importantly, bedside decision-making.
So we're looking for that absolute leading edge of deterioration. Like, what is going to kill them first?
Yeah, what are the subtle clues, the hemodynamic shifts you're totally missing while you just stare blindly at the pulse ox?
So we're going to unpack the pathophysiology, the exact cellular mechanisms of decompensation, and that real intensivist thinking that separates, a task-oriented provider from a true resuscitationist.
Let's do it.
Let's start with the fundamental paradigm shift. When we talk about acute respiratory failure, or ARF, the very first mental hurdle is recognizing that it's not a primary disease.
No, not at all. It is a symptom.
Yeah.
And it's a catastrophic secondary symptom of failing gas exchange.
Right.
It reflects the collapse of this incredibly delicate physiological balance. But it's never a standalone pathology.
Yeah.
You always have to hunt for the underlying trigger.
And broadly speaking, this failure kind of bifurcates into 2 distinct mechanisms, right? Hypoxemic failure and hypercapnic failure.
Oxygenation versus ventilation.
Okay, let's isolate hypoxemic failure first, the classic type 1.
Sure.
We're defining this as a PaO2 of less than 60 millimeters of mercury on room air at sea level. The core issue here is just inadequate exchange of oxygen across that alveolar capillary membrane.
Right, and when we look at the etiology, the overwhelming majority of these cases, they trace back to what we call a VQ mismatch.
VQ mismatch. So walk us through that physiology.
Well, in a completely theoretical, perfectly mathematical lung, the volume of gas reaching the alveoli, which is ventilation, or V,
Okay.
would perfectly match the volume of blood perfusing those pulmonary capillaries, which is perfusion, or Q. So the VQ ratio would be a perfect 1.0.
But human anatomy doesn't really work like that.
No, not at all. Even in a totally healthy athlete standing upright, gravity creates regional disparities. Up at the lung apex, you have higher ventilation relative to perfusion. It's essentially physiologic dead space. But at the lung bases, gravity pulls the blood, so you have higher perfusion relative to ventilation.
So the whole system just averages out to a functional ratio of, what, about 0.8?
Exactly, about 0.8. So the pathology starts when that regional averaging completely falls apart.
I always think about it like a warehouse supply chain issue.
Oh, I like that. Walk me through it.
So the pulmonary blood flow, that's your fleet of delivery trucks, right?
Yeah.
And the alveoli are the loading docks.
Okay.
So if the loading dock doors are jammed shut by, say, a massive mucus plug in severe COPD, or clamped shut by severe bronchospasm in status asthmaticus.
The truck arrives, but there's no cargo to load.
Exactly. The blood just flows right past an alveolus that has absolutely no fresh oxygen to offload.
And that right there is a primary ventilation defect causing the VQ mismatch. Because the blood continues through the pulmonary circulation and dumps back into the left atrium completely deoxygenated.
It just mixes with the oxygenated blood from the healthy lung units.
Right, this venous admixture, it just drives down the overall systemic arterial oxygen content.
Wow. And we can flip that supply chain analogy for a primary perfusion defect, right? Like the loading docks are wide open, fully stocked with fresh oxygen, but the delivery truck never makes it past the checkpoint.
A pulmonary embolism is the classic mechanism there.
The PE physically obstructs the flow.
Yeah, the clot blocks pulmonary arterial flow. So the alveolus is beautifully ventilated, but it becomes entirely dead space because, well, no blood is actually participating in gas exchange.
So whether the initial insult is impaired ventilation or impaired perfusion, the downstream physiologic change is the exact same, isn't it? Regional hypoxia.
Yep, which immediately triggers the sympathetic nervous system. Your compensatory mechanisms just slam into high gear.
The massive catecholamine release.
Exactly. Alpha and beta receptors are stimulated, and that drives tachycardia to increase cardiac output and tachypnea to increase minute ventilation.
The body is just frantically trying to compensate for that widening alveolar arterial oxygen gradient.
But then this is the crucial intensivist realization. Those compensatory mechanisms have a massive metabolic cost.
Right. They take energy.
A ton of it.
Yeah.
The respiratory muscles, particularly the diaphragm and your accessory muscles, the sternocleidomastoids, intercostals, they're suddenly doing marathon level work.
So they demand way more oxygen.
Which is the exact resource the body is lacking. So when oxygen delivery fails to meet this skyrocketing consumption, that's when you hit decompensation.
And within this whole hypoxemic framework, there's an extreme, highly lethal variant of VQ mismatch that we really need to isolate, right? The true intrapulmonary shunt.
Oh yeah, the shunt. A true shunt is an extreme VQ mismatch, where the VQ ratio is essentially zero.
Zero.
Blood exits the right side of the heart and enters the left side without ever participating in gas exchange.
I mean, we see this anatomically with congenital cardiac defects, like a VSD with right-to-left flow, but in the ICU, we're primarily fighting capillary shunts.
Right. Going back to your warehouse analogy, the loading dock isn't just jammed with mucus.
The entire building is completely submerged underwater.
That is a perfect way to picture it. Complete alveolar flooding.
Like in severe low-burn pneumonia.
Yes, severe pneumonia, where the alveoli are just packed with purulent exudate, or cardiogenic pulmonary edema, where hydrostatic pressure has forced plasma into the air spaces. The alveolus is totally non-functional.
So blood flows past it, but the capillary interface is just entirely blocked by fluid.
Yes, and this dictates a massive, massive change in our clinical approach.
Because you can't treat it the same way.
Exactly. If you have a patient with a standard VQ mismatch, say, mild asthma, putting them on a nasal cannula or a non-rebreather mask really helps.
Right. You increase the FiO2, steepen that diffusion gradient, and drive more oxygen into those partially obstructed areas.
But if that warehouse is underwater, if you have a true capillary shunt, just pumping more oxygen into the external environment does absolutely nothing. I mean it. You can crank the FiO2 to 100%. You can blast them with high-flow nasal cannula, and their PA2 will barely budge.
Because the oxygen simply cannot physically displace the fluid or penetrate that consolidated exudate?
Right, it's refractory hypoxemia. Oxygen therapy alone is useless.
So what do?
You just have to introduce positive pressure. CPAP, BiPAP, or mechanical ventilation with PEEP. You have to mechanically stent those fluid-filled alveoli open and literally push the fluid back across the interstitial space.
Okay, let's shift to the other side of the coin. Hypercapnic respiratory failure, or type 2.
Let's do it.
We're talking about a PeCO2 greater than 50 millimeters of mercury, paired with acidemia, so a pH less than 7.35.
And this isn't an oxygen exchange problem at the membrane at all. This is a mechanical clearance problem.
Right.
It is primary ventilatory failure.
Yeah.
The alveolar capillary membrane might be perfectly intact, but the bellows system, the mechanical pump moving air in and out of the lungs, is failing.
You just have inadequate minute ventilation.
Yes.
Minute ventilation being respiratory rate times tidal volume. If either of those drops significantly, CO2 just rapidly accumulates. So what are the primary triggers causing that mechanical pump to fail?
Well, we categorize them by the level of the failure. It can start at the very top, the central nervous system.
Like an overdose.
Exactly. A massive opioid overdose, severe brainstem trauma, or a stroke affecting the medullary respiratory centers. It physically blunts the central drive to breathe.
So the lungs are completely fine, but the brain just isn't sending the signal.
Right. Then you move down the chain to the chest wall.
Structural issues.
Severe structural abnormalities. Think flail chest from blunt force trauma, where paradoxical chest wall movement prevents generating that negative intrathoracic pressure.
Or what about severe obesity hypoventilation syndrome?
Yes, where the sheer mechanical weight of the adipose tissue on the chest and abdomen simply overcomes the diaphragm's ability to expand the thoracic cavity.
And finally, you have neuromuscular transmission. The brain sends the signal, the chest wall is structurally intact, but the wiring is just faulty.
Guillain-Barré syndrome, myasthenia gravis crisis, ALS, or even lingering effects of neuromuscular blocking agents right there in the ICU.
The action potential just fails to adequately stimulate the diaphragm.
Exactly. And the physiological cascade here is so insidious. The patient hypoventilates. CO2, which is highly soluble, rapidly diffuses into the blood and combines with water to form carbonic acid.
Now, if this were a chronic process like severe COPD, the kidneys would have days or weeks to compensate, right, by holding onto bicarbonate to buffer the pH.
Right, but in an acute hypercapnic failure, the kidneys do not have time to react. So the pH plummets, causing profound respiratory acidosis.
And that rising CO2 has immediate dangerous hemodynamic effects, particularly in the brain, doesn't it?
Oh, absolutely. Carbon dioxide is a potent cerebral vasodilator. So as the PiCO2 climbs, the cerebral blood vessels dilate, increasing intracranial pressure.
This is why the hallmark clinical finding of acute hypercapnia isn't necessarily a respiratory symptom, it's a neurological one.
Exactly. Somnolence, lethargy.
They look incredibly sleepy, difficult to arouse.
They often complain of a severe, throbbing morning headache. If you don't recognize that somnolence as hypercapnic failure, and you just assume they are, tired or sedated, they will quietly retain CO2 until they code from profound acidosis and cardiac arrest.
Wow. Let's drill down into that cellular level for a minute. Why is hypoxemia specifically so universally lethal? Like, we talk about it clinically, but what is the actual mechanism of death at the tissue level?
It all comes down to basic mitochondrial respiration.
Going back to biology class.
Yep. The Krebs cycle and the electron transport chain demand oxygen as the final electron acceptor to produce ATP, our cellular energy currency.
Right.
When PO2 drops below a critical threshold, aerobic metabolism just grinds to a halt. The cells are forced to survive on their backup generator, which is anaerobic glycolysis.
Which is an incredibly dirty and inefficient system.
It produces a tiny fraction of the ATP and generates a massive amount of toxic byproduct, lactic acid.
And as lactic acid accumulates, it dissociates into lactate and hydrogen ions.
Yes. The body attempts to buffer these hydrogen ions using its circulating bicarbonate stores. But the bicarb is quickly depleted.
You blow through the buffer and the blood pH drops. You develop a high anion gap metabolic acidosis.
And that acidic environment is catastrophic for cellular machinery.
Yeah.
Enzymes denature. But the most immediate threat is to the sodium-potassium ATPase pumps on the cell membranes.
Because they run on ATP.
Exactly. Without sufficient ATP from aerobic metabolism, these pumps fail. Sodium rushes into the cells, pulling water with it, causing the cells to swell and lyse.
They just pop.
Yep, and potassium leaks out, causing hyperkalemia and lethal cardiac dysrhythmias.
Plus, that acidic environment blunts the effect of endogenous catecholamines, right? And any vasopressors we administer.
It does.
Yeah.
The heart muscle loses its contractility. You enter irreversible shock, multi-system organ failure, and cellular death.
From a jammed loading dock to total cellular lysis, it happens terrifyingly fast. So, knowing this physiological cliff edge, what is the bedside reality? What is diagnosis, planning, implementation, and evaluation? Let's start with early assessment. Walk me into that room.
Okay, so you do not wait for the oxygen saturation to drop into the 80s to realize your patient is in trouble.
Because pulse oximetry is a lagging indicator.
Exactly. It's too late. The brain is the most oxygen-sensitive organ in the body. The very first signs of hypoxemic failure are neurological and behavioral.
A sudden sympathetic surge.
They become restless, agitated, apprehensive. They might start picking at their IV lines, pulling at their gown, trying to get out of bed. They just look panicked.
And this is a major clinical pearl for exams and the bedside. If a previously calm patient suddenly becomes confused and combative, your first thought should never be delirium or sundowning.
Never. Your first thought, your first action must be to rule out hypoxia.
Absolutely.
You will also see the cardiovascular compensation. Unexplained tachycardia, maybe a slight bump in blood pressure from the catecholamines, and tachypnea. They are breathing 28, 30 times a minute.
Then we progress to the classic signs, the things you see from the doorway.
Severe dyspnea. They are utilizing maximum accessory muscle effort, You see intercostal retractions, tracheal tugging.
They are locked in that tripod position.
Yeah, they're physically trying to mechanically force their posterior chest diameter open. They're using pursed lip breathing, instinctually trying to create their own endogenous PEEP to keep their airways from collapsing during exhalation.
And they can only speak in 2 or 3 word bursts.
Exactly.
Now let's talk about the late, highly dangerous signs. The stuff that means you are minutes away from a code blue. We really need to shatter a massive myth here regarding cyanosis.
Oh, cyanosis is a terrible clinical indicator.
Right.
Waiting for a patient to turn blue is waiting for them to die. Cyanosis is a very late sign of profound hypoxemia. And more importantly, it is highly unreliable because it depends entirely on the absolute amount of deoxygenated hemoglobin, not the percentage.
Let's break the math down on that because it's a huge exam trap and a massive bedside blind spot.
So central cyanosis doesn't typically become visible until you have at least 5 grams per deciliter of completely deoxygenated hemoglobin circulating in the capillary beds.
Okay, 5 grams.
Let's say you have a healthy patient with a normal hemoglobin of 15. If they desaturate and 5 grams become deoxygenated, they will turn blue.
Sure.
But consider your typical ICU patient who might have had a GI bleed. Their total hemoglobin is only 7.
Wow, okay. So for that anemic patient to show 5 grams of deoxygenated hemoglobin, their oxygen saturation would have to be catastrophically low.
They would likely be in pulseless electrical activity or asystole before they ever turned blue.
They simply do not have enough hemoglobin to manifest the color change.
Never rely on color. Rely on the brain, the heart rate, and the work of breathing.
Which brings us back to that terrifying scenario I mentioned in the hook. The patient who is breathing 40 times a minute, sweating, utilizing every ounce of muscle mass to pull air, and suddenly their respiratory rate drops to 14.
That is the ultimate clinical trap. A novice nurse sees a normal respiratory rate of 14 and thinks, oh, the bronchodilators are working, the patient is calming down.
But a seasoned intensivist sees a rate of 14 in that context and reaches for the intubation equipment.
Without hesitation.
Why? What just happened physiologically?
The underlying VQ mismatch or shunt has not resolved. The patient did not get better. Their respiratory muscles simply ran out of ATP.
The diaphragm is just exhausted.
Completely. They're entering respiratory muscle fatigue and impending respiratory arrest. The drop in respiratory rate is the moment they literally surrender to the hypoxia. You have single-digit minutes to secure that airway before the heart stops.
Terrifying. So, diagnostics. We obviously want a stat chest x-ray to look for the etiology, right? Consolidation, pneumothorax, pulmonary edema. We are tracking continuous SpO2. But the gold standard is the arterial blood gas.
Always. The ABG gives you the precise PO2 to confirm hypoxemia, the PCO2 to diagnose hypercapnia, and the pH to determine if the patient is exhausted their buffering capacity and slipped into acidemia.
And our nursing diagnoses here are pretty straightforward. Impaired gas exchange and ineffective breathing pattern leading to inadequate tissue perfusion.
Yes.
The measurable goals in our planning phase are simple but critical. The patient will maintain an independent airway, effectively clear secretions, and return to baseline ABG parameters within our targeted timeframe.
Which leads us to implementation and priority nursing actions. This is where we rank our interventions. First, next, then.
Okay, the absolute priority, the first action when you recognize respiratory failure.
Apply oxygen. It sounds basic, but you must intervene immediately to protect the brain and myocardium.
But with a caveat, right?
Yes. The intensivist caveat is applying the lowest possible FiO2 to achieve an SpO2 greater than 90% or a PO2 greater than 60. We do not want to cause oxygen toxicity or absorption atelectasis by washing out all the nitrogen in the lungs with 100% IO2 unless absolutely necessary.
Got it. Next priority action, positioning.
Maximize their respiratory mechanics. Sit them up, at least 30 to 45 degrees, ideally sitting on the edge of the bed with arms resting on an overbed table.
So you use gravity to pull the abdominal viscera away from the diaphragm, allowing for maximum downward excursion.
Exactly.
And there is a very specific hemodynamic maneuver here for unilateral lung disease, isn't there? Say you have a patient with massive lobar pneumonia in just the right lung. Their VQ matching in that right lung is terrible, but the left lung is perfectly healthy.
This is where you utilize gravity to manipulate pulmonary blood flow.
How so?
Pulmonary perfusion is highly dependent on gravity. Blood flows preferentially to the dependent lung zones, basically whichever part of the lung is closest to the floor. So if you lay that patient on the right side, the sick lung is dependent. Gravity pulls the majority of their cardiac output into the consolidated right lung, which just wildly exacerbates the intrapulmonary shunt. Their oxygen saturation will plummet.
So you employ the good lung down strategy.
Exactly. You position them on their left side in the lateral decubitus position. The gravity pulls the blood volume into the healthy, well-ventilated left lung.
You physically match the perfusion to the optimal ventilation.
Yes, it is a brilliant non-pharmacological way to instantly improve their PO2.
Okay, then our third priority, mobilize secretions.
If the underlying cause is pneumonia, COPD, or cystic fibrosis, you must clear the airway. Hydration is key to thinning out thick, tenacious mucus, but you have to monitor their fluid status closely if they have right-sided heart failure or cor pulmonale.
And we use specific coughing techniques, right? Like augmented coughing or quad coughing.
Right, for patients with neuromuscular weakness, like spinal cord injuries or severe fatigue, you place the palms of your hands at the base of their rib cage. As they attempt to exhale, you forcefully push upward and inward.
You are acting as a manual diaphragm.
Exactly, increasing intra-abdominal pressure to generate the explosive force needed to clear a mucus plug.
Or huff coughing.
Yeah, teaching the patient to take a deep breath and exhale forcefully while whispering the word huff. This keeps the glottis open and creates a series of mini coughs that mobilize secretions from the smaller airways up to the larger airways.
And it does that without causing the intense bronchospasm and exhaustion of a deep, hacking cough.
Right.
Okay, let's talk pharmacy. We're running parallel interventions here. What medications are we pushing?
Short-acting beta-2 adrenergic agonists, albuterol.
The classic.
The MOA is stimulation of the beta-2 receptors in the bronchial smooth muscle, causing rapid bronchodilation. It opens those loading dock doors, but you have to monitor for adverse effects.
Like what?
High doses of albuterol lose their beta-2 selectivity and start stimulating beta-1 receptors in the heart.
And the patient is already tachycardic from the hypoxia.
Exactly.
Yeah.
You can drive their heart rate into the 150s, inducing myocardial ischemia or dangerous tachyarrhythmias. You have to balance the need for an open airway against the cardiac strain.
We are also giving IV corticosteroids like methylprednisolone.
Yes, to attack the underlying airway inflammation.
Yeah.
But remember, they are not rescue drugs. They take hours to exert their full genomic effect.
And we have to monitor for acute complications there too.
Definitely. Steroids drive potassium into the cells, worsening hypokalemia, which is super dangerous if you're also giving albuterol, because albuterol also causes hypokalemia.
Double whammy.
And steroids induce gluconeogenesis, causing severe hyperglycemia, which impairs wound healing and increases infection risk in the ICU. You will very likely need to start an insulin drip.
All right, now we arrive at a massive safety alert regarding medications in acute respiratory failure. The patient is thrashing, they are pulling at their mask, they are agitated. The natural instinct is to just calm them down with a benzodiazepine like lorazepam or a narcotic like morphine.
Do not heavily sedate a hypoxic patient who is not mechanically ventilated.
But decreasing anxiety decreases oxygen consumption and the work of breathing, doesn't it?
It does, but you must remember why they are agitated. Their brain is suffocating. The agitation is a survival mechanism.
Wow.
If you push IV lorazepam, you suppress their central respiratory drive. You mask their clinical deterioration. They will look beautifully calm, right as they slip into hypercapnic coma and respiratory arrest.
So treat the hypoxemia first. Secure the airway first. Sedation follows ventilation, never the other way around.
Exactly.
So when are we escalating?
You are notifying the provider for any upward trend in oxygen requirements or worsening ABGs, but you are calling a rapid response or preparing for an immediate code if you see maximum accessory muscle use, that sudden drop in respiratory rate we discussed, or paradoxical breathing.
Paradoxical breathing being when the diaphragm is completely fatigued. So as the patient tries to inhale, the chest wall expands, but the abdomen is sucked inward due to the negative intrathoracic pressure pulling that flaccid diaphragm up.
It is a sign of total ventilatory failure. You are intubating that patient immediately.
Okay, let's wrap up acute respiratory failure with our 5 things framework. If you remember only 5 things from this section, what are they?
Number 1, core pathophysiology. It's a failure of oxygenation, fundamentally driven by VQ mismatch or true shunt, or a failure of ventilation driven by pump failure.
Number 2.
Key assessment finding. Early mental status changes. Agitation and restlessness signal low O2. Profound somnolence signals high CO2.
Number 3.
Most dangerous complication. Respiratory muscle fatigue leading directly to respiratory arrest.
Number 4.
Priority nursing action. Administer oxygen utilizing the lowest effective FiO2, position upright or good lung down, and clear secretions.
And number 5.
Most important treatment. Treat the underlying etiology while aggressively supporting gas exchange, often escalating to non-invasive positive pressure ventilation like BiPAP or intubation.
Give me the one-sentence clinical picture of a patient sliding off the cliff into ARF.
A restless tachycardic patient locked in a tripod position, speaking only in two-word gasps, displaying paradoxical chest movement as their respiratory rate begins to ominously slow.
And if you see blank, think blank, and do blank.
If you see a tachypneic asthma patient suddenly develop a normalized respiratory rate accompanied by lethargy, think catastrophic respiratory muscle fatigue and impending arrest, and do call for immediate intubation and mechanical ventilation.
Perfect. We are going to pivot now. We've established the baseline of acute respiratory failure. Now we look at its most violent, terrifying, and life-threatening form, acute respiratory distress syndrome, or ARDS.
ARDS is the 800-pound gorilla of the ICU. It is a sudden, progressive form of acute respiratory failure characterized by massive, uncontrolled systemic inflammation.
The alveolar capillary membrane, which should be whisper-thin to allow for gas exchange, is just structurally destroyed.
It becomes highly permeable to large molecules and intravascular fluid.
And despite decades of advancements in mechanical ventilation and critical care pharmacology, the mortality rate for ARDS still hovers around, 35 to 40%?
It's stubbornly high. It accounts for a massive percentage of ICU admissions. And while it can be triggered by direct lung injury, like aspirating gastric acid, near drowning, or severe viral pneumonia, the most common cause is actually indirect.
Which is overwhelming systemic sepsis.
Particularly from gram-negative bacteria. The infection might be in the gut or the urinary tract, but the inflammatory cascade it triggers travels through the bloodstream and treats the pulmonary capillary bed as ground zero for an immune system war.
Let's break down the pathophysiology of that war. The source material divides ARDS into three distinct phases. Phase 1 is the exudative, or injury phase, occurring 24 to 72 hours after the initial insult.
The initial insult triggers a massive release of pro-inflammatory cytokines.
Tumor necrosis factor, interleukins.
Right, and this summons neutrophils straight to the pulmonary microcirculation. These neutrophils degranulate, releasing toxic mediators, reactive oxygen species, and proteases.
The intent is to destroy pathogens, but the friendly fire completely shreds the delicate alveolar capillary membrane.
The structural integrity is just gone. The tight junctions between the endothelial cells fail.
So capillary permeability skyrockets. Protein-rich fluid, plasma, and red blood cells pour out of the vascular space, flooding the interstitium and then crossing right into the alveolar space.
The alveoli literally drowned from the inside out. This is the exudative phase.
But the fluid isn't the only problem, is it? The inflammatory mediators specifically target and destroy alveolar type I and type II pneumocytes.
And that's devastating. Type I cells provide the structural architecture of the alveolus, but type II cells produce surfactant.
Surfactant being that amphipathic molecule that lowers surface tension.
Exactly. According to Laplace's law, without surfactant, the smaller alveoli require massive amounts of pressure to stay open.
This is where we bring in the dish soap analogy.
I love this one.
Surfactant acts like dish soap on water, breaking the surface tension. Without it, the wet inside walls of the alveoli stick together like a wet, deflated plastic bag. You try to pull the sides apart, but the tension is just too strong.
Exactly. When the type II cells are destroyed, surfactant production simply ceases. The alveoli undergo massive widespread collapse. This is profound atelectasis. Now you have lungs filled with protein-rich fluid and the alveoli are collapsed tight.
And as that protein-rich exudate sits in the alveoli, it coagulates.
Yeah, fibrin, necrotic cells, and inflammatory proteins form a thick, stiff layer called a hyaline membrane that coats the inside of the alveoli.
This creates the physiological hallmark of ARDS, stiff lungs.
Pulmonary compliance plummets. It takes immense pressure just to push a small volume of air into these scarred, fluid-filled sacs.
And because you have massive alveolar collapse and fluid flooding, you have basically created the ultimate intrapulmonary capillary shunt.
Which brings us to the defining clinical hallmark of ARDS, refractory hypoxemia. The patient's POU2 is dangerously low. You turn the vent up to 100% FiO2. But the oxygen cannot cross the thick hyaline membrane, and it cannot enter the collapsed alveoli.
Blood flows through the pulmonary bed without ever picking up a single molecule of oxygen.
The hypoxemia is entirely refractory to supplemental oxygen.
Okay, after this initial devastation, we enter phase 2, the reparative or proliferative phase, usually 1 to 2 weeks after the injury.
The body attempts to heal, but it does so poorly. There's a massive influx of fibroblasts and inflammatory cells. The fluid is slowly reabsorbed, but the lung tissue is replaced with dense fibrous tissue.
The pulmonary vascular bed gets obliterated by this fibrosis, leading to severe pulmonary hypertension,
which places massive strain on the right ventricle of the heart.
Now, if the inflammatory cascade is halted, the lesions can sometimes resolve, right? But if it continues, the patient enters phase 3, the fibrotic phase.
This usually happens 2 to 3 weeks in. The lung is permanently remodeled. The normal architecture is completely replaced by diffuse scarring and massive fibrosis.
The surface area for gas exchange is just permanently and drastically reduced.
Pulmonary compliance is practically non-existent. If a patient reaches this phase, the prognosis for meaningful recovery is exceptionally poor. They will likely suffer long-term ventilator dependence.
So, given this catastrophic internal cascade, what is our assessment? How does this actually present clinically?
The terrifying part of ARDS is how subtle the early signs are.
Really?
Yeah. During that initial 24 to 72-hour window after the sepsis or trauma, the patient might just exhibit mild dyspnea and slight restlessness. If you auscultate, you might hear scattered fine crackles.
And the ABG at this early stage might actually look like a simple respiratory alkalosis, right? Because they are hypoxemic, so they hyperventilate, blowing off CO2 and raising their pH.
Exactly. But as the capillary leak accelerates and the alveoli flood, the symptoms rapidly escalate into profound respiratory distress. Severe hypoxemia, massive tachypnea, suprasternal and intercostal retractions. They look like they are suffocating because they are.
And the chest x-ray changes dramatically.
It evolves from relatively clear to a bilateral diffuse alveolar infiltrate. It's what we call a whiteout.
Because normally, air on an x-ray is radiolucent, it looks black.
But in ARDS, because the lungs are entirely consolidated with fluid and hyaline membranes, the x-ray is radiopaque. It looks completely white, like a blizzard has covered the lungs.
Now, a core diagnostic metric for ARDS and a huge focus for intensivist decision-making is the PFF ratio, the PaO2 divided by the FiO2. Why do we rely on this calculation rather than just looking at the absolute PaO2?
Because a PaO2 of 80 means very different things depending on how much support the patient is receiving. If my PaO2 is 80 on room air, I'm doing fine. If a patient's PaO2 is 80 while they're on a ventilator receiving 100% pure oxygen, their lungs are failing catastrophically. The PF ratio standardizes the oxygenation deficit. It tells us precisely how efficiently the lungs are transferring the oxygen we give them into the bloodstream.
Let's run the math to make this concrete for the exam.
You take the PO2 from the arterial blood gas and divide it by the FiO2 expressed as a decimal.
Okay.
A normal healthy person on room air has a PO2 of roughly 95. Room air is 21% oxygen, or 0.21. So 95 divided by 0.21 is roughly 452. A normal healthy PF ratio is greater than 400.
Now let's take a patient in our ICU. They are on the vent. We've got the FiO2 cranked to 90%, which is 0.90. We draw a gas, and their PO2 is only 83.
You calculate 83 divided by 0.90. The PF ratio is 92.
That is a staggering drop in efficiency.
It is, and it categorizes the severity according to the Berlin definition of ARDS.
Yeah.
Mild ARDS is a PF ratio between 200 and 300. Moderate ARDS is between 100 and 200. Severe ARDS is a PF ratio of less than 100. Our patient at 92 is in severe ARDS.
Wow. Now let's talk pattern recognition and differentials. This is a crucial diagnostic pivot point. A patient comes into the ER or decompensates in the ICU. Severe shortness of breath, bilateral crackles on exam, dropping oxygen saturation, and a chest x-ray showing diffuse pulmonary edema.
It could be ARDS representing a non-cardiogenic pulmonary edema.
But it could also be classic congestive heart failure, cardiogenic pulmonary edema. The treatments are radically different. How do you distinguish them?
You have to look at the hemodynamics and the mechanism of the fluid leak. In cardiogenic pulmonary edema, the left ventricle of the heart is failing. It can't pump blood forward efficiently.
So the pressure backs up into the left atrium and then backs up to the pulmonary veins and capillaries.
Right. The hydrostatic pressure inside the capillaries gets so high that it physically forces fluid out into the alveoli. But the capillary membrane itself is perfectly healthy and intact.
Whereas in ARDS, the heart pump is typically functioning fine. The fluid leak is because the capillary membrane has been chemically shredded by inflammation. It is a permeability issue, not a hydrostatic pressure issue.
So to differentiate, we look at cardiac pressures. If you have a pulmonary artery catheter in place, you look at the pulmonary capillary wedge pressure, or PaOP.
Okay.
In heart failure, because of that backup of pressure, the wedge pressure will be elevated, usually greater than 18 millimeters of mercury. In ARDS, because the left ventricle is fine, the wedge pressure is typically normal, less than 18.
Or we can use bedside echocardiography.
Exactly. An echo showing a severely reduced ejection fraction points to cardiogenic edema. A normal EF points to ARDS.
Yeah.
You also rely heavily on the clinical history. Do they have a history of severe heart disease, or do they just come in with a massive systemic infection?
Once we diagnose ARDS, we face a massive therapeutic paradox.
You really do.
The lungs are stiff, leaky, and incredibly fragile. The immediate threat is the hypoxemia, which will kill the patient. But to treat the hypoxemia, we have to use mechanical ventilation, and the secondary threat is that the ventilator itself will destroy whatever functional lung tissue is left.
It's called ventilator-induced lung injury, or VAGI. Because the ARDS lung is so stiff, it has practically zero compliance. It takes a massive amount of pressure to force air into it.
Right.
If we program the ventilator to deliver a standard normalized breath, a normal tidal volume of, say, 10 to 12 milliliters per kilogram, that volume is going to seek the path of least resistance.
It's not going to go into the stiff, consolidated, collapsed alveoli. It's going to rush into the few remaining healthy alveoli.
And because you are forcing a huge volume of air into a very small percentage of functional lung tissue, you wildly overdistend those healthy alveoli. You stretch them beyond their physical capacity until they literally rupture.
This is volutrauma and barotrauma.
Yes, you pop the alveoli, causing pneumothorax, and you trigger even more inflammation called biotrauma.
So how do we ventilate a lung without destroying it? We use the ARDS-NET protocol, low tidal volume ventilation.
We drastically reduce the size of the breaths. We target a tidal volume of 4 to 8 milliliters per kilogram of ideal body weight.
Now, ideal body weight is critical there. Why do we calculate it based on their height and gender rather than their actual weight?
Because lungs don't grow when you gain fat. A person who is 5'4" and weighs 300 pounds has the exact same size lungs as a person who is 5'4" and weighs 130 pounds.
Wow, right.
If you calculate tidal volume based on their actual 300-pound weight, you will deliver a massive volume of air and instantly cause barotrauma.
Okay, so we are delivering these tiny protective breaths, but minute ventilation is tidal volume times respiratory rate. If we drastically cut the tidal volume, minute ventilation drops. CO2 clearance plummets. Their PaCa2 is going to rise.
It will.
Aren't we intentionally causing the very hypercapnic respiratory failure we just said was dangerous?
Yes. We are intentionally inducing respiratory acidosis. It is a strategy called permissive hypercapnia. And this is the absolute essence of intensivist decision-making, choosing the lesser of two evils. We allow the PaCa2 to rise, sometimes up to 60 or 70, as long as the arterial pH stays above 7.3 or 7.25.
We tolerate the acidic environment to save the physical architecture of the lung.
Exactly. The human body can actually tolerate a gradual, mild acidosis. It shifts the oxyhemoglobin dissociation curve to the right, the Bohr effect, which decreases hemoglobin's affinity for oxygen and makes it easier to offload oxygen to the starving tissues.
But what the body cannot tolerate is the ventilator shredding the lungs with 40 centimeters of pressure.
Right. We accept the high CO2 to prevent catastrophic barotrauma.
Now, to fix the refractory hypoxemia, we have to address the collapsed alveoli. We use PEEP, positive end expiratory pressure.
PEEP is constant pressure applied by the ventilator at the very end of exhalation. It essentially acts as a mechanical splint. It forces the collapsed alveoli to pop open, a process called alveolar recruitment, and it prevents them from collapsing again when the patient breathes out.
And in ARDS, because the lungs are so heavy and wet, we often have to use very high levels of PEEP, right? Sometimes 15 to 20 centimeters of water pressure just to keep the alveoli open and push the fluid back across the membrane.
But PEEP is a double-edged sword.
Okay.
It has profound hemodynamic consequences that every nurse and provider must anticipate.
This is a classic exam trap and a daily bedside reality. High PEEP puts immense positive pressure inside the thoracic cavity.
And what sits right in the middle of that high-pressure thoracic cavity? The heart and the massive, thin-walled vena cava returning venous blood to the right atrium.
Exactly. That high intrathoracic pressure physically compresses the inferior and superior vena cava.
It chokes off the blood returning to the heart. Venous return plummets. When venous return drops, right ventricular preload drops.
And if there is no blood filling the right ventricle, there is no blood reaching the left ventricle. Left ventricular stroke volume drops. Cardiac output plummets.
So you turn up the PEEP to fix the oxygen saturation, and 3 minutes later, the patient's mean arterial pressure drops to 45. They are in severe hypotensive shock.
You have to constantly ride that razor's edge. You are balancing the airway pressure needed to recruit the lungs against the pressure the cardiovascular system can tolerate without collapsing.
If the PEEP is failing, or we can't turn it up any higher without tanking the blood pressure, we use positioning. Prone positioning. Physically flipping the intubated, critically ill patient onto their stomach.
It is a massive, labor-intensive undertaking. It takes a specialized team of 4 to 6 people to safely maneuver a paralyzed patient with a breathing tube, central lines, and a Foley catheter.
But the physiological payoff can be miraculous.
Walk us through the anatomy of why proning works so well.
You have to visualize the lung mass.
Yeah.
The largest portion of human lung tissue is actually located posteriorly in the back. When a patient is lying supine, on their back, the weight of their heart, the abdominal organs pushing up, and the heavy, fluid-filled edematous lung tissue all compresses that massive posterior lung zone. The alveoli in the back are completely crushed.
But the alveoli in the front, the anterior ones, remain open.
Right, but gravity pulls all the pulmonary blood flow down into the crushed posterior zones.
So you have a massive VQ mismatch. All the blood is going to the crushed lung, and all the air is going to the anterior lung that has very little blood flow.
Yes, but when you flip them prone onto their stomach, you completely reverse the physics.
The previously crushed posterior alveoli are now on top.
They are freed from the weight of the heart and the mediastinum. They naturally re-expand and recruit. Meanwhile, gravity pulls the pulmonary blood flow down to the anterior alveoli, which are now dependent and well ventilated.
You radically improve VQ matching, mobilize secretions, and drastically improve oxygenation. We often leave them in the prone position for 16 hours a day.
It's game-changing.
Let's talk about fluid management in these patients. Their blood pressure is often soft because of the high PEEP and the systemic inflammation from sepsis. The reflex might be to bolus them with IV fluids to boost their preload.
You must resist that reflex. Remember the pathophysiology, their pulmonary capillaries are completely shredded and permeable. If you aggressively pump them full of normal saline or lactated ringers to raise their blood pressure, a massive portion of that fluid will leak straight out of the vascular space and into the lungs, profoundly worsening the pulmonary edema.
We want to keep them dry, a conservative fluid strategy.
If they are hypotensive, we lean on vasopressors like norepinephrine to squeeze the vasculature rather than relying on volume expansion.
But what if they go into acute kidney injury, which is common in sepsis, and they become fluid overloaded? They need dialysis to pull the fluid off.
Standard intermittent hemodialysis pulls off large volumes of fluid in a very short time, 3 or 4 hours. An ARDS patient's hemodynamics absolutely cannot tolerate those rapid fluid shifts. Their blood pressure will bottom out immediately.
So we use CRRT, continuous renal replacement therapy.
It's essentially 204/7 slow-motion dialysis. It gently pulls off small amounts of fluid continuously over 24 hours. It allows us to manage their volume status and correct their severe acid-base imbalances without causing catastrophic hypotensive shock.
Let's address the medications required for this level of ventilator support. To tolerate low tidal volume ventilation and permissive hypercapnia, the patient has to be perfectly synchronized with the ventilator.
If they buck the vent, if they try to exhale while the machine is pushing a breath in, airway pressures spike massively and you cause barotrauma.
So if heavy sedation isn't enough to synchronize them, we have to use neuromuscular blocking agents, NMBAs, drugs like cetracurium or vecuronium.
These drugs cause complete chemical paralysis of the skeletal muscles, including the diaphragm. It absolutely stops the patient from fighting the vent. It also completely eliminates the work of breathing, which drastically reduces the body's overall oxygen consumption, reserving that precious oxygen for the brain and heart.
We monitor the depth of paralysis using a peripheral nerve stimulator, often checking the train of 4 response.
But there is a massive, non-negotiable safety alert when using NMBAs. Paralytics have 0 analgesic or amnestic properties.
0.
They do not control pain, they do not sedate the patient, and they do not alter consciousness.
So if you push a paralytic without first establishing deep, continuous IV sedation and analgesia,
The patient will be fully awake, fully aware of their surroundings, unable to move a single muscle, unable to take a breath, and in absolute unmitigated agony from the endotracheal tube in their throat and the invasive lines in their neck.
it is the definition of psychological torture.
You must ensure concurrent administration of deep sedatives like propofol or midazolam and analgesics like fentanyl, and you should monitor their sedation depth using a BIS monitor if available.
What other complications are we anticipating? What else threatens an ARDS patient besides the hypoxemia and the ventilator?
Ventilator-associated pneumonia, or VAP, is a massive secondary killer. The endotracheal tube bypasses all the upper airway's natural defenses. The cough reflex, the cilia, bacteria from the oropharynx slide right down the tube into the lungs.
So we implement the VAP bundle aggressively.
Elevate the head of the bed 30 to 45 degrees to prevent aspiration. Perform rigorous oral care with chlorhexidine to reduce bacterial load. Provide stress ulcer prophylaxis, and conduct daily spontaneous awakening trials and spontaneous breathing trials to assess if we can get that tube out as quickly as possible.
You mentioned stress ulcers. Why are they at such high risk for GI bleeding?
When the body is in severe hypoxic shock, the sympathetic nervous system shunts blood away from non-essential organs to prioritize the brain and heart. The gastrointestinal tract is deeply underperfused.
So the ischemic stomach lining breaks down and ulcerates rapidly.
Exactly. So we preemptively administer proton pump inhibitors like pantoprazole.
We also have to prevent deep vein thrombosis from the paralysis and immobility using chemical prophylaxis like enoxaparin and sequential compression devices.
And we cannot ignore the psychological toll. The critical care community is increasingly recognizing post-intensive care syndrome.
Survivors of ARDS endure profound cognitive deficits, severe muscle wasting from prolonged paralysis, and devastating PTSD.
They experience vivid, terrifying hallucinations from the sedation and the illness. The lungs might show structural healing on an X-ray a year later, but the psychological trauma requires intensive, long-term psychiatric rehabilitation.
Okay, let's lock this down. Section 9. ARDS wrap-up and 5 things. What are the absolute critical takeaways?
Number 1. Core pathophysiology. ARDS is a syndrome of massive systemic inflammation causing severe capillary leak, destruction of surfactant, alveolar collapse, and refractory hypoxemia.
Number 2.
Key assessment finding. The PO2 remains dangerously low despite maximum FiO2 delivery, accompanied by a bilateral whiteout on the chest X-ray and a PF ratio indicating severity.
Number 3.
Most dangerous complication. Barotrauma and volley trauma caused by ventilating stiff lungs, paired with catastrophic drops in cardiac output caused by high PEEP compressing venous return.
Number 4.
Priority nursing action. Anticipate immediate intubation, coordinate prone positioning to recruit posterior alveoli, and rigorously enforce the VAP bundle and deep sedation protocols before paralysis.
Number 5.
Most important treatment. ARDS-NET protocol. Low tidal volume ventilation to protect the lungs, accepting pervasive hypercapnia, utilizing optimal PEEP, and maintaining a conservative dry fluid balance.
Give us the one-sentence clinical picture of ARDS.
A septic patient whose oxygen saturation plummets and refuses to rise despite 100% FiO2, whose chest X-ray transforms into an opaque blizzard, and whose lungs become so stiff they require massive ventilator pressures just to deliver a minimal breath.
And if you see blank, think blank, and do blank.
If you see a severe ARDS patient on high levels of PEEP suddenly experience a dramatic drop in their mean arterial pressure and cardiac output, think decreased venous return secondary to excessive intrathoracic pressure, and do notify the provider immediately to assess intravascular volume status, adjust vent settings, or initiate vasopressor support.
We have journeyed from the microscopic failure of a sodium-potassium pump deep in a hypoxic cell all the way through the macromechanics of alveolar recruitment, PEEP, and hemodynamic collapse. It's an incredibly complex interplay.
And the future of how we manage this is rapidly evolving. We are shifting from reactive management to proactive precision medicine.
I want to leave you with a thought based on emerging research in our source material. We know that sepsis is the primary trigger for ARDS, but we also know that millions of people get sepsis and only a fraction of them develop the catastrophic lung injury of ARDS. Why?
Genetic predisposition.
Precisely. The research is pointing heavily towards specific genetic biomarkers that dictate the intensity of an individual's inflammatory cascade. Imagine the future of the ICU. A patient is admitted to the emergency department with early pneumonia. Before their lungs ever start to leak, before the surfactant is destroyed, we draw a rapid genomic assay.
The bedside panel identifies them as having the high-risk biomarker for ARDS.
So we don't wait for the whiteout on the X-ray.
We don't wait for the failure. We immediately administer a targeted biologic, a specific monoclonal antibody that blocks that exact inflammatory pathway. We neutralize the cytokine storm before the neutrophils ever invade the pulmonary capillaries.
We prevent the disease from ever manifesting.
We move from trying to salvage shredded, stiff lungs on a ventilator to preemptively protecting the capillary membrane. That is the true frontier of critical care.
Predicting the storm and altering its course before the first drop of rain ever falls in the lungs, that is a staggering thought to end on. Well, that brings us to the close of this intensive review. Mastering this 80-20 knowledge, understanding the why behind the what, is what builds an elite clinician. When you step into that murky diagnostic landscape, you aren't just looking at the pulse ox anymore. You're looking at the physiology, the trends, the hemodynamics, the brain, and the heart. Goodbye, and keep diving deep.